45 years old male with persistently raised BP. Her previously clinical readings were 156 by 80 mmHg. So GP organized for him to have a BP monitoring, which shows 138 by 85 mmHg. He is on maximum dose of ramipril, that is ACE inhibitor. Which second line agent would be most appropriate to add? Here the patient is poorly controlled hypertensive, already taking ACE inhibitors. The second line agent will be calcium channel blockers or a thiazide diuretics. So according to the NICE guidelines for the management of hypertension, we will add calcium channel blockers or a thiazide diuretics such as indapamide. Here verapamil is a rate limiting calcium channel blocker, so it is not used in the management of hypertension. The correct answer will be indapamide. If potassium greater than 4.5 millimole per liter, bisoprolol and doxycycline can be added as a fourth line agents in resistant hypertensive patients, where ACE inhibitor, calcium channel blockers and thiazide have been tried. Similarly, spironolactone can be added as a fourth line agent when potassium levels are lower than 4.5 millimole. In the next slide, you will see how we will manage patient according to the guidelines and ICE guidelines. 46 years old woman admitted from GP with recurring intermittent episodes of chest pain. Recent investigation shows ECG at rest, normal sinus rhythm with no abnormalities. Exercise stress test shows STL depression in V1 and V3 leads. Blood samples for trop T shows less than 5 nanogram per liter. First and second both trop T were same and within normal range. Coronary angiography were also normal. Which of the following cardiac syndrome is most likely to be the cause of this woman's chest pain? First option is Brugada syndrome, that is conduction abnormality associated with arrhythmia. ST elevation in V1 and V3 are seen on ECG. Second option is cardiac syndrome X. People with cardiac syndrome have normal coronary angiograms despite ECG changes on exercise stress test. It is also called microvascular angina. Third one is Eisenmenger syndrome, that is reversal of left to right shunting leading to cyanotic right to left shunting in congenital heart disease. Fourth option, unstable angina, that is cardiac chest pain coming on at rest without evidence of troponin rise and without ischemic ECG changes. Wolff Parkinson White syndrome, that is electrical conductivity disorder. Delta waves are seen on ECG along with shortened PR interval. So here the option is cardiac syndrome X correct. In the next slide, you will see some points regarding syndrome X. Which of the following features is not part of the modified Dukes criteria used in the diagnosis of infective endocarditis? So, focus on the question that they are asking not part of the modified Dukes criteria. So, don't be confused. Now, let's see the options. Options are prolonged PR interval, positive serology for Coxella, fever greater than 38 degrees centigrade, Roth spots, positive microbiology for embolic fragments. Here, all the options are correct except option number A, that is prolonged PR interval. This is the diagnostic criteria for the rheumatic fever. 38 years old with no past medical history is referred to the clinic after an abnormal ECG finding identified as part of a pre-operative workup. Long QT syndrome is identified on repeat ECG. On further questioning, the patient reports that his father had a heart condition in his 20s. He is unsure of the specific diagnosis and has experienced previous episodes of syncope following exertion. The patient is started on a beta blocker and a plan to insert an implantable cardioverter defibrillator is made. A loss of what function is associated with this patient condition? So here the answer is potassium channels. Long QT syndrome usually due to the loss of function or blockage of calcium channels. Long QT syndrome is an inherited condition associated with delayed repolarization of the ventricles. It is important to recognize that it may lead to the ventricular tachycardia or torsido T-pointus and therefore can cause collapse or sudden death. Other options are AV node dysfunction or blocks that results from several conditions including fibrosis, sclerosis and drugs. However, they result in PR interval changes that is prolonged and do not affect the QT interval. The second option is calcium channels. There are multiple calcium channels involved in both electrical and mechanical functions of the heart. Mutation of these channels can result in cardiac dysarrhythmia syndrome, such as Brugada, and early repolarization syndrome, but they are not associated with long QT syndrome. Dysfunction of the SA node can result from several different conditions, but it is not associated with long QT syndrome and is normally identified via abnormalities with the P wave. Dysfunction of the sodium channel can be associated with certain conditions, including those resulting in prolonged QT syndromes. However, a loss of function of these channels is far less likely in long QT syndrome when compared to the potassium channel. So, the option potassium channels is correct.